Thank you, Dr. Mir, for giving me this opportunity. I have two apologies to make. One, of course, to replace Professor Pradeep Sharma, which are too large a set of shoes to step into. And of course, I just hope I just don't trip over them. And secondly, as Dr. Mihir said, unfortunately, we were late in the Sonu Sona things, as Dr. Pradeep Sharma said. I'm not sure how many of you were there. It was a good place to observe post-alcohol or alcohol-induced nystagmus. I'm sure Dr. Hurtle would have experienced many patients who would have complained of nystagmus after an extensive bout of alcohol. And of course, Sonu Nigam added to that. So those who missed it really missed something entertaining as well as medically stimulating. So I'll just talk about managing nystagmus. Again, I'm not saying much because many of the slides are not there, but we've talked about how to measure and we've been discussing we've talked about a video nystagmography and electronystagmography. We were doing electronystagmography before we were able to get the video nystagmogram, which unfortunately is prone to breakdown. So we're hopefully looking for a better model. But that's what we tends to be run slow. So just a bit because Dr. Mihir has shown us a lot of squiggly lines. And there's not so many things that we can understand. I just wanted to say that this is what we also pick up when we are looking at head posture. So you want to just understand the VNG or even an ENG, which will give you adequate information when you're looking at a head posture. So you're looking at the straight gaze. These are the horizontal. These are for the left and right eye for the horizontal, and this for the vertical. So you can see a lot of eye movement happening in the horizontal gaze in the center. This for dextroversion and this for levoversion. You can see that. I'll just show you one of the images of Dr. Hurter also, by which we understand what is actually happening. Why is the patient seeing? And this is occlusion, right or left occluded. This is to pick up a change in the nystagmus intensity or the waveform after occluding one eye, so in the fusion maldevelopment syndrome. And this is when you ask the patient to see very clearly what is the best, and you are able to document that the nystagmus is minimum and measure the deviation. So that's the best time where you have evidence that this is the best to measure the head posture. The aims of treatment is to improve visual acuity if possible, decrease oscillopsia, which sometimes, I'm not sure how much Dr. Hurtle would agree, but some patients with infantile nystagmus syndrome are able to appreciate that the image is moving, although it's not incapacitating for them. So I always tell you, don't take that as an acquired nystagmus. A patient with acquired nystagmus would be very, very symptomatic. The oscillopsia would be really difficult for him, but these patients would be continuing with their normal daily life, but would be able to tell you how the image shakes. And the other thing that we do is the shifting of the null zone to the primary position. And in those where we have manifest nystagmus, that's a good action to do. Whereas the manifest latent nystagmus, who have a head turned towards the eye of towards the fixating eye, would also benefit by, as was discussed, by managing the squint itself. This is the image I've taken from Dr. Hurtle's article, and what I wanted to show was that, just to understand how a patient with nystagmus sees, it's at this time when the eye is about 3 degrees off the fixation point that the patient is seeing, and any intervention that we are doing is aimed to keep the eye within this position for a longer period of time, and the patient will be happier. So increase the breadth of the null zone when the patient is looking. So there are a lot of things you can intervene. We've talked about refractive correction. We've talked about drugs and neurosurgery. So this is somewhat a kind of appearance that you have where all you can intervene. We've done a set of cases, of course. We've talked about contact lenses. We've also done auditory biofeedback studies. So all these things act to improve the oculomotor control. We did a study on acupuncture, and it was very interesting because the patients during the acupuncture process were extremely happy. So you can see this was the nystagmus prior to insertion of the needle. This is 5, 10, 15, and 20 minutes. They do feel better. There is some improvement in the visual acuity, but after you remove the needle, they tend to start going back. In fact, we tried to see if we could make some collar which would constantly stimulate the sternocleidomastoid, and the patients would be better. But well, as of now, there is nothing like this. But this was an interesting concept that we felt that acupuncture may improve. And of course, we've talked about yoga, relaxation, which may have an impact. So Surgical options include to induce adduction convergence that has been talked, to shift the null position to the primary position, and to reduce the amplitude of nystagmus. So essentially, your intervention in infantile nystagmus syndrome is based on these basic principles. We've talked about to induce adduction or convergence, you can do a bimedial recession. This would dampen this is for damping this. The most important thing you need to do is to test with prisms preoperatively. So you have to see that the patient with the prisms does feel that he improves and he is seeing binocularly. So do a binocular testing of these patients. Otherwise, post-operatively, you may have intractable diplopia if they are not able to fuse. If they are not able to add on that fusional versions, which would be helping them to dampen the nystagmus, they will have intractable diplopia and you will have to go back and reverse it. So this is the most important consideration you need to have when you're doing this kind of surgery. For correction of face turn, again, it would be a repetition of a lot of work which Dr. Hertel has talked about. So you have the Kastenbaum's procedure, the Anderson's procedure. We at our center are using the augmented Anderson's procedure where we are doing large recessions of the yoke muscles. Essentially, the aim, I would say, of course, open for correction, but the essential aim is that if they has a head posture, you're actually kind of doing a squint surgery in either eye and moving it in primary gaze. So you're moving the null point from an eccentric null position to a primary gaze null position. So that's the real impact of a face turn surgery. So again, various techniques have been described. As we know, we do various ways in which we tackle the same squint. There are different schools of thought. So you can do a recess resect procedure in all four horizontal recti. As I said, we prefer the augmented Anderson's. The augmented Anderson's, we do the medial rectus recession of 9 millimeters and the lateral rectus recession of 12 mm. So it's on the yoke muscles, the eye that is in abducted position, the lateral rectus is done, the adducted position eye, the medial rectus is done. So the effect is more on the medial rectus. That is why you do less amount of surgery on the medial rectus. The advantages what we felt of the augmented Anderson's over any others which we had done was that there is only mild limitation of movement. The horizontal recti are available, the two others are available to do a resect procedure if you have an undercorrection. It's a very easily reversible procedure. You can get back, advance the muscle, and sometimes there is a chance that you miss a pan. As Dr. Hertel has pointed out, sometimes we do spend a little less time with our patients than what a patient of nystagmus really deserves. So if you have accidentally operated on a pan, or else you have got an overcorrection, you have the other two recti available to correct that, or else, as I said, if you have a pan, then you can actually do the recessions of the other two horizontal recti that are remaining. So that's one of the ways, and you convert an augmented Anderson's to an all four recti recession procedure. So this was a patient with preoperative eye movements that you can see. He had this head posture and we shifted it. So this is the primary gaze ENG that we are showing. Again, null in levo, and this was the correction post-operatively. And this was just to show you that, you know, as the child is reading down, now you're getting the real null position that you need to correct for. So the child walks in straight. Often the child will not tell you that. I mean, the parents will tell you that he occasionally, in fact, all these children are severely reprimanded by their parents that keep a head posture, don't keep a head posture, keep it straight, keep it straight. And, you know, often they just are unwilling to show you that head posture. So this is post-operatively as he's reading down the Snell's chart, you can see that his head posture is definitely improved. I would say that, you know, 100% correction of the head posture is not really possible. Of course, by multiple surgeries, maybe vertical head postures have been discussed by Dr. Hertel. Again, you can do vertical recti resection procedures for the same. It does tend to be a problem if you have a horizontal squint along with that. For obliques, Dr. Hertel talked about the recti shifts, and we have done a couple of cases where we did the oblique muscle surgery to try and correct for the head tilt. This was one such patient where we had a child with the head tilt, and we did the oblique muscles, recession and anterior tenectomy of the superior oblique to get a correction of the torsion that the child had, and he was better in the post-operative period. And just the last section of our intervention to decrease the amplitude, which will help to decrease the excursion, as there would be a change in the waveform and again the flattening of the curve, which will improve the visual acuity, which is supposed to improve and do the effect. So you have two surgeries which we have tried. One is the supramaximal recession resection of all four recti, and of course the Hurtle Deloso procedure, which is the all four recti tenotomies. It's just like doing the augmented anisons on both sides. So you can do an LR recession and an MR recession on both the eyes, and that tends to place it retroequatorially. It tends to dampen the nystagmus. It has been shown that there is definite improvement in the initial post-op period. It is cosmetically good. Patient satisfaction is fairly high. You do document about a line or two of improvement in the visual acuity. It affects by improving foveation time, and there is very little limitation of movement. There is a risk of consecutive exotropia that has been reported by many who've done this procedure. So that's important that you need to be careful for that. So you have to measure. That's why I'm saying the MRs are more effective as weakening procedures on them. So we do it. So it is supposed to be almost 1.5 times more effective. So proportionately we change the surgery for the horizontal recti. Oh, sorry. And of course, Dr. Hurtle is here about this surgery, which he'll talk about. We had done a study at our center where we had compared the two procedures. Of course, it was not a large study. It was done on 6 patients in each of the two arms, the Hurtle Deloso procedure in one set of 6 patients, and the all 4 recti recessions in the other set of 6 patients. And we did not find any significant difference in the whole process. In fact, this was done 3-4 years earlier, and at that time we were ourselves not so convinced of the procedure. And we had told all the patients that we are admitting you and we are doing this procedure today. And, maybe we'll have to go in and do the, other arm of the surgery in the next OT, but thankfully we didn't require that. So effectively, of course, as more and more experience is coming and as Dr. Hurtle is here to tell us more about it, I won't really talk much about it, but my impression and understanding is that, there is still a lot of work left for nystagmus patients, and whatever little we do, we just one step ahead in kind of solve their problem. Thank you, Dr. Meir, to give me this opportunity.